I'll share my screen.
Awesome. Perfect. Hi, everybody. We will give everyone just a couple of minutes to get logged on, and then we'll go through some housekeeping things and jump right into our content. So as everyone is getting logged on this evening, we just want to welcome you to our event tonight. My name is Brooke McGivern. I am a speech pathologist and the Director of Marketing and Communications here at Tim's Medical. If you are interested in accessing ASHA CEUs for this presentation, we ask that you stay for the duration of this presentation, and then there is a survey to complete at the conclusion of the course. So I'll pop that into the chat. It will also be sent out via Zoom emails. So if you, for some reason, don't get the email from Zoom, just go ahead and send us an email at tims-univ@tims.com. Additionally, if you are tracking your own CEUs or like PDHs and want a certificate of completion, just send us an email at tims-univ@tims.com and we will send you a customized certificate of completion. And then finally, if you are interested in rewatching this presentation will be live on our website under our Tim's University On Demand offering. So that will be up in the next couple of days. So with that, I'll go ahead and pass it over to Dr. Stephanie Watts and Jess Gregor. And if you have any questions about logistics, feel free to pop them in the chat and I will answer them as they come in. Thanks, everybody.
Hello, good evening. Thank you so much for joining us tonight. This is a lecture entitled An Interactive Case Review, Critical Decision Making in the Era of a Dichotomized Swallowing. I am Dr. Stephanie Watts. I'm a speech pathologist and assistant professor and chief of speech pathology at the University of South Florida at the USF Health Voice Center. And I'm joined by my amazing partner, Jess Gregor. I'll let you introduce yourself.
Hi, I'm Jessica. I am a speech pathologist. I'm at the Mayo Clinic in Phoenix, Arizona. And I've been practicing for 15 years and work with the wonderful Dr. Watts. And we've started esophageal collab, which we'll talk about a little bit later.
And just to review some of the objectives and agenda tonight, we hope to, by the end of this, have you be able to identify aspects of a case history which might assist in critical decision making, review the importance of following a framework for esophageal screening, and participate in discussion of educational demands in the era of a dichotomized swallowing. And we tonight will go over case introductions, kind of weighing what we know, following a framework and why, review of etiology of this dysphagia case, and then talk a bit about the educational demands, where we are, and discuss a bit. This is an interactive case review, so there's a picture of a cell phone up there and a QR code. So when the QR code comes up, feel free to scan and participate, and everything is anonymous. So we can all just kind of share in the discussion. So I hope to make this very conversational. So a bit about the case history. This starts off with a 27-year-old male. His past medical history is significant for reflux, not really well controlled with PPI, and otherwise quite healthy. He comes to our multidisciplinary clinic with this problem swallowing solids, sensation of hang up high in the throat, prolonged meal times, and the inability to gain weight due to difficulty eating. His FOIS score, or functional oral intake scale, is 7, despite having difficulty eating. So he some dysphagia, but he has no really restrictions with his diet. And the onset was about 10 years ago. So he may be in his early teens. And he also notes that at age 10, he may have had some difficulty eating and drinking. He notes abdominal pain with eating and no known preceding event to his dysphagia. His current diet, he, like I said, is a FOIS, so regular solids versus soft solids is tolerated. Sometimes if he feels the sensation of hang up, he'll kind of avoid a certain meal and turn to soft solids, but he rates himself as eating and drinking regularly without restriction. Drinks thin liquids. His medications are whole and takes those with thin liquids. And problematic foods for him include meats, breads, and dry foods. Compensatory strategies include going slow, chewing quite a bit, and moistening foods. His weight is stable, although he's having some difficulty gaining weight. He's a 27-year-old male, works out, would like to gain a little bit more weight, but it takes him so long to eat that it's kind of difficult. So he's using some liquid supplements like proteins, ensures, things like that. And let's move on to reviewing his PROMs. This here is the pill 5. It's a validated outcome measure with a score out of 20. The higher score, the worse perception of dysphagia. And his pill 5 was a 3 out of 20, noting that there might be some fear of taking pills, interferes with his ability to take new medications or supplements and vitamins like large non-coded. And some of his pills or vitamins that are non-coded, such as some like big things like magnesium, he has to kind of coat in a pudding or something like that. If we review his eating assessment tool, or EAT-10, this here is a validated ordinal scale, and the maximum score is out of 40, with a higher score indicating a much more prominent features of dysphagia. He reports a 15 out of 40, which really reaches our cutoff for investigating the dysphagia symptoms. Most pertinent is he feels that sometimes his swallowing issue interferes with his ability to go out for meals. Although, again, despite rating himself as, full oral intake, he does find it quite bothersome. So the pleasure of eating is affected by his swallowing. He rates that a 3. When he swallows, food sticks in his throat. Again, he does point to his throat more than his chest. And like I mentioned, swallowing is slightly stressful for him, thinking about that food might be sticking, or if he's doing something quickly at work, he really has to kind of take his time and slow down. Finally, we gave him the Reflux Severity Index, or RSI. The RSI has a maximum score of 45, with the higher score indicating more probability of reflux, and his score was 11 out of 45, noting that he had the sensation of something sticking in his throat, sometimes intermittent breathing difficulty or choking episodes. So let's take a look. So this patient was seen in a multidisciplinary clinic. So how we run ours is that all the new patient evaluations are seen by myself and a laryngologist. So one of two. So there are the surgeons in our practice, and the laryngologist that I work with is an esophagologist as well. And we start off by doing a comprehensive head and neck exam, cranial nerve exam, a laryngoscopy, stroboscopy, and an introductory fees. And so I've trimmed this down to look at his certain swallow during his fees, but his cranial nerve exam was unremarkable. His head and neck exam was unremarkable, completely normal and within normal limits for all of the physical exam that we had performed together. And here's a 10 ml of thin liquid. An ml of thin liquid. And what we notice, there is some invasion of the liquid into the laryngeal vestibule at the level of the vocal fold, and that went subglottic. So he aspirated on this exam. Furthermore, he has retention at the pharyngoesophageal segment, which when you do a bear down remover, that does retropulse. So we can see that. I'm going to play that again just because it's hard to fully see. First time around. So we did a 10 ml, a 5, 5, 10. And I'll stop it here for us. So we see invasion of liquid into the laryngeal vestibule, resting here, anterior portion of the vocal cords. And then when he breathes, we can see that that went subglottic. In addition, we see hang up here at the PES. And when he does a bear down maneuver, that retropulses even more like that. We have him clear his throat several times and swallow, which does assist with clearance of the aspirant liquid. Okay. So we were a bit surprised, given the complete normal picture of his head and neck exam, his cranial nerve exam. And so together we decided, what should we do next? And so if you don't mind joining in the poll and letting me know what you think you might do next.
Don't worry, it's completely anonymous. Please
Yeah.
participate.
Up to 56, 57 participants. I'd like to try and get to about 80. I think the majority of respondents would like to do an MBS next.
We're almost there. Ooh,
Yeah,
10 more.
almost there. Just a few more people weighing in.
Super, thank you.
Perfect. And feel free to unmute yourself, kind of start a conversation if you're comfortable. What makes you believe that we should do an MBS next?
Brooke, are they able to unmute or should they type into the chat?
They should type into the chat.
Okay.
Okay.
If anyone feels comfortable, just adding a little smidge on why they feel the VFSS is warranted.
Stephanie and Jess, it says that the chat is disabled, so they're not able to
Bummer.
right now. Sorry, I'll try to enable it for you guys.
Okay.
That's
Thanks.
why they're not able to answer you right now.
Oh, okay, no worries. I'll keep
Thank you
going.
for trying.
So what we chose is to get an MBS next. So we'll review this thin liquid. We follow a standardized protocol, 5, 5, 10 cup sips, serial cup sips. And so we're watching that unfold here. What we notice is you didn't
Sorry,
add,
Steph, I'm going to interrupt really quick. The chat is now enabled, you all. Sorry.
Oh, thank you. Steph, do
thank
you want
you.
to pause for a second? We can see what a couple people say before you
Sure.
explain
Yeah,
the fluoro
I'm
findings.
I'm just kind of interested in kind of why we might choose therapy first and why we might choose a
So
VFS.
Genevieve says, I would want to see the UES. We have another person saying, you want to get a comprehensive assessment because we don't have an etiology of dysphagia. Jaleesa wants to say, or I want to see an esophageal sweep. What's happening below the PES? We don't have enough information to inform therapy. A lot about esophagus and check the drain, the best
Nice.
phrase ever.
Nice.
Yeah, so I mean that's great, guys. This is excellent.
I agree. So let's watch this again. This is starting with thin liquid. Again, we use a standardized protocol coming from 5, 5, 10 single cup sips, serial cup sips. And what we notice is that we continue to see a bit of postprandial residue, kind of coating the posterior pharyngeal wall, slightly in the follicular space, kind of mild, but it's there, and corresponding to what we saw in the fees. No aspiration events here, but what we do notice is there's a small anterior web. Okay. Probably best seen on these larger volumes. So a small anterior web, ever so slight. ever so slight, it's there, a wee little web that creates a bit of retention at the pharyngoesophageal segment that retropulses into the pharynx there. Okay.
And just so you guys know, fluoro is obviously excellent in identifying these things, but even with fluoro, webs can be missed. We usually see a lot upon autopsy in cadavers because they hide, with it being kidney bean shaped, they like to hide and they're not always elucidated with fluoro, but the larger volumes will usually do that.
Yeah, so there are some great views of this little anterior web there, which we may, contribute to some of the issues, a little bit of tightness, retropulsion into the from the pharyngoesophageal segment into the piriforms there, ever so slight, but could certainly begin to explain some issues with solid foods. Yep, like larger bolus volumes. And so as we look at the puree bolus and progress through our study, we see that the retention becomes a little bit more. Again, it's a slight wet anterior web, not easily seen with puree and solid, but we start to see a gradual increase in the retention there. And we continue to our solid bolus. You can also see he's making some neck, like postural adjustments, showing us that he's a bit uncomfortable with the process. So kind of moving his head forward, and he does have retention.
Effortful.
And it's effortful for him, which wasn't described, from his complaints. But definitely we can see why he noted on his E10 that he had, kind of going out to eat, had to pick certain things or it was a little stressful for him. And you can see how that's evident there. So logging back on, what should we do next? Should we get this patient scheduled for swallowing therapy as soon as possible? Should we go a little bit lower to the cervical esophagus to see what could be happening? Look in AP. Should we go lower to the aortic arc? Should we go all the way through the esophageal sphincter? Should we send this patient back to his PCP so we can get next steps initiated? Or should we start some therapy while the patient awaits additional workup from the PCP? That's F all the way at the bottom there.
Mhm. Steph, do you want to get 80 people again or?
Yeah, I want a good portion of the folks that are here.
And we appreciate your honesty too. It's very,
Absolutely.
very awesome to see this.
Yeah, thanks for participating. I know it's late at night, at least it is here on the East Coast. Okay. Oh, we've got 83. Awesome. So a lot of folks would like to screen to this lower sphincter. Some are saying we should maybe stay a little bit higher, cervical esophagus, maybe to the level of the aortic arc, halfway between there. There's a few people say, send them back to the PCP. Let's see, plan for them to have next steps, and start therapy while they await.
Steph, can we ask them to put in the chat for those who feel like they shouldn't go all the way to the LES? What might the rationale be for that?
Sure. Yeah, that's a great question. Just to drive discussion.
Please feel free to use the chat if anyone's comfortable who chose screen to the cervical esophagus or screen to the aortic arc. Just why you want to stop there, I guess, is the question. Someone want to see esophageal motility, right?
Okay.
Do you think like those levels then would be sufficient for that? Hold on, we got a few more.
It's so interactive tonight, guys. Thanks.
No, no one else.
Okay. Well, what we chose to do for this case was to complete a screening protocol, so a framework called the Robust Esophageal Screening Test, or the REST. And in this case, what we do is follow a solid, 2 liquid swallows, and a barium tablet. And we follow these bolus trials from the mouth through the lower esophageal sphincter into the stomach. And one of the liquid swallows remains at the level of the LES to wait for full distension at the LES. And so there's 4 trials total. And we're going to watch as this gentleman undergoes the rest. So he swallows a solid bolus and we follow that down. We, very much so past the cervical esophagus, past the aortic arc here. And now we're in the distal esophagus, watching the bolus go through into the stomach, checking back to see what's left, checking back in at 30 seconds, checking back in at a minute. We still see quite a bit lingering. And so when we're talking about aortic arc, we're right up here, this level. We give him a sip of water to see if anything kind of washes through there. Now we give him a sip of liquid barium, and we follow that from the mouth to the stomach. He had a double swallow there, so we're waiting for that secondary swallow. Okay, screening back up. Okay, and now the third trial, we remain at the level of the LES. So you stay down here and you wait for the liquid to pass. Okay. And then finally you give a barium tablet with water. He's having some hesitation as he reported. There it goes. So he swallows the barium tablet and we follow that down to make sure it gets into the tummy, which it does not. So we screen at 30 seconds and a minute. Okay. And we allow for him to take a sip of water to try and wash it down. It doesn't wash anything down. So this is just looping back. But what we see here are the definitions, operational definitions for pass and fail. It is a screening protocol, so there's a pass and a fail. Either they completed the tasks and was deemed normal per the definitions, or they failed per the definitions. Some of the definitions lend themselves to more of an anatomic abnormality to report, and some lend themselves to more of a motility issue to report, but always using nomenclature that's well within the purview of the speech pathologist. And so when we think about this particular screening, this patient failed the esophageal screening rest for liquid as tapering of a barium column when the esophagus was maximally dilated. So the esophagus was maximally dilated and there was a tapering of that column and there was a deviation of the straight normal contour. Okay, and what that looks like is, a very clearly defined anatomic issue. So we may have missed that, just quickly screening. We absolutely would have missed that if we stayed in the cervical esophagus, which is up top. We absolutely would have missed that if we stayed at the level of the aortic arc. And we would have missed it if we didn't have this great view just at the level of the LES. Having a nice size bolus trial to really distend. And this brings out what's later reported as a very tight, pretty severe esophageal stricture. You can see just these really tapered edges here reaching across the esophagus. So that's a really tight stricture. And then we see that the 12.7 millimeter barium tablet gets stuck for well over a minute and doesn't clear even when he takes a sip of water.
Stephanie, can I ask a question from the
Sure.
chat? So first, though, someone did so nicely volunteer some information that the reason they don't go below the maybe mid-level of the esophagus is that their radiologist is hesitant or resistant to doing anything lower, which thank you for putting that in the chat, because that's so many SLPs are battling this issue. But then another person asked specifically with the 12.7 millimeter tablet, why is it given with water? Is it because regular water, excuse me, would like barium would obscure the view is the question.
Yeah, absolutely. So just taken with water. If you need to give a barium tablet with anything else for safety concerns in the oropharynx, then you can put that barium tablet in puree. But the idea is we want to understand and report on the circumference of any narrowing, predicted circumference, right?
Thank
Um,
you.
Yeah, so those were great questions. And I'm sorry for whoever said that the radiologist won't go lower. Um, Lots more research coming out to kind of help you in that way. But just staying in the cervical esophagus certainly doesn't tell us anything. Staying at the aortic arc doesn't tell us anything. A lot of the pathology is going to be at the level of the LES, certainly for an anatomic issue. Um, and we'll talk a little bit later about why. Well, let's just go along with the case and see why that's so. For his diet recommendations, total oral diet, I did say both of us, the physician and myself, felt that kind of regular diet as tolerated, chew well, that type of thing. But his pills, pills and thin liquids, crushed if possible. He didn't really take many medications. He was on a PPI that wasn't really controlling his reflux, and taking liquids unrestricted, but try to stick to single bites. In terms of swallowing strategies, we did recommend one single effortful swallow to clear the pharynx of residue and reduce aspiration risks. And certainly when you swallow multiple times, you can cancel out the peristaltic wave in the esophagus, so not to continuously swallow and kind of exacerbate his already existing esophageal issues. For the food pipe, we suggested to flush each solid bite with a liquid swallow. So alternate, eat slow, chew well, take small sips, small bites. If sensation of retention arises, pause and don't recline a few hours before eating. We didn't recommend treatment at this time because there was really no oropharyngeal impaired mechanism. It was all due to increased pressures from the esophagus, contributing to increased pressures in the UES and this retention in the pharynx. So me doing effortful swallows really wouldn't help this patient achieve anything. He might come back like later after surgical workup, but certainly not to start with me. So we recommended that CCGI and then of course our laryngologist. And in this case, we also suggested that he undergo an esophagogastroduodenoscopy, also known as the EGD or upper endoscopy. And this is a sedated procedure performed by the GI or ENT with specialty training. And the EGD is meant to examine the upper GI tract, including the esophagus, the stomach, the duodenum, which is the first part of the small intestine, and biopsy the tissues. And with this exam, which is not a screening, you can visualize the mucosa, structural abnormalities, and most importantly, take biopsies. In our clinic, we do this awake with transnasal esophagoscopy or TNE. And so it's, a scope through the nose, and then the patient swallows the scope. And so we also see and visualize the esophagus. We can take biopsies, brush biopsies, and dilate as well. A little harder to tolerate awake, but people can do it. So what we found through biopsy was something called eosinophilic esophagitis. And EOE is a chronic immune-mediated disease. It's characterized by symptoms related to esophageal dysfunction with predominantly eosinophilic inflammation. And that's just a little histology of what it looks like under histology. There are varied functions of the eosinophil, which is a pro-inflammatory white blood cell. And it takes part in a lot of inflammatory processes, especially allergic disorders. And we tend to call it the asthma of the esophagus. And this inflammation, this constant inflammation, can lead to strictures. And it's usually diagnosed by endoscopy and, of course, biopsy. And what the histology reveals is an eosinophil count that's greater than 15 per high-powered field. Now, the tricky part about taking these biopsies is that the physician should be taking in multiple areas, because you can have eosinophils in one area of the esophagus and not in the other. So multiple biopsies throughout the levels of the esophagus are warranted. And luckily, he was under great care. Proper amount of biopsies were taken, and his histology did reveal EOE. So I'm just going to click on all the things to click on here. So effector cells in our body respond to a stimulus, and they perform functions in our immune system to defend the body. And there are two kinds specifically associated with eosinophilic esophagitis, and those are the eosinophils and IL-13. And the presence of these cells, the immune-mediated cells, they drive fibrosis, right? They drive changes in the cellular structure, the cellular matrix of these tissues, which hardens and turns into strictures. And this narrowing, the strictures can occur throughout the esophagus. Another case was a very young 14-year-old boy with a very long segment stricture. He had EOE as well. And you might see, this happening as early as the adolescent age. These immune mediated cellular responses in these folks with allergies, reflux, and whatnot. So I'm going to go back there. So common difficulties that you might see in kiddos are gagging, a delay in advancing solid food introduction, food refusal, failure to thrive. And common things you might see in young adults are solid food dysphagia, impactions, prolonged meals, and undernutrition is common in both. Undernutrition is less common in folks who can adhere to dietary restrictions, like adding Boost and Ensure, and kind of work around until they finally kind of end up at your door for a swallow evaluation, because it's gotten to the point where it's very uncomfortable, and etc. But you can see these behaviors start in infants and small children and advance through the ages. And this is a really nice schematic of the progression of problems from inflammatory responses from infancy to adulthood. And so it's really important to ask questions regarding the onset of dysphagia and progression, because we see it fits in very nice for him that he's having abdominal pain all the way to dysphagia. Hasn't quite met the food infection yet, thank goodness. We got to him early enough. But in another case study that I've shared in the past, this young boy had feeding difficulty even as a toddler. So his mother reported feeding difficulty, gagging. That's why he was coming to see us, failure to gain weight. And then we see this 27-year-old man present with this pain and dysphagia. So you really can see how this chronic immune-mediated inflammation of the esophagus forming strictures in the esophagus and being reported as both oropharyngeal and esophageal dysphagia kind of manifest itself. And then we see the clinical presentation of EOE. Typically white males over 40 predominate the individuals who may present to you. About 70% of those individuals, they might have conditions like asthma, dermatitis, food allergies. When you see that more in children. Heartburn, that's non-responsive to medical treatment, so their PPIs aren't working for them. And as we've discussed, You do see a lot of solid food dysphagia, the food impactions, depending on how bad the strictures are or how long the segment of strictures are, abdominal pain, because it is painful to have food sticking in your chest, and also kind of delays uh, you know, absorption and food and things like that. And then regurgitation. So your patient might say, I'm eating, and then food kind of comes back up on me. And they might be slow, picky eaters since childhood. So prolonged meal times, they may have adjusted over the years and gotten used to it. But something's bringing them to your doorstep for a swallow study. And Jess, I'm going to hand this over for you. What our GIs do about it, the 3Ds.
Yes, the 3Ds. So dilation, diet, and drugs. And just note that obviously dilation is not treating the underlying cause, diet and drugs do. But it's just important to know that dilation is obviously what the GI is going to do for the strictures. And, just remember that EOE is this allergic inflammatory disease. So it's inflammation of the esophagus in response to an allergen or a set of allergens. So if you really want to treat the underlying cause, you have to remove the allergen or a set of allergens causing the allergic inflammation. So, okay, dilation we got. For diet, there are a number of different diets that have been devised over the years that various GIs will use. But one of the most common ones is known as the 6-food elimination diet. So that's dairy, eggs, wheat, soy, shellfish, and tree nuts. And so what they want you to do is eliminate all of it, scope, another EGD, and then reintroduce one at a time. And so when inflammation spikes, then it's the trigger, and then you end up with this list, and you really want to avoid those foods forever. But some studies suggest that eliminating just dairy is highly effective and will capture many, many people without having to go through the eliminations of these other items. And in a close second is wheat. And also one of my dear GI colleagues wants everyone to know that food allergy and skin allergy testing is useless in this population. Those are his words. Because the skin surface testing that one would do with an allergist is not going to show what the esophagus does. They're not the same thing. They're not simpatico. And again, no blood test is going to show it. It's like, he called it, it's not a type 1 hypersensitivity like anaphylaxis, where your tongue goes numb or your lips swell. The kind of inflammation that they're looking for is this like chronic smoldering inflammation. And so there are a lot of endoscopies, a lot of EGDs, but that's really the standard of practice now when managing with EOE. And then we move on to drugs, which we'll talk on the next slide.
That was such a great way, this chronic smoldering and that was such a great way to describe
That
it, but
stuck with me. Yeah.
it's true. And that schematic that I showed earlier was just such a good, I love that picture. It's not very bright and colorful, but it's so spot on. From infancy to adulthood. And I've seen the spectrum of cases present with dysphagia, and just how much more severe it gets over the years. And those are those effector cells, right? Like slowly making changes as it's responding to try to defend the body, right, from these allergens, and causing the problem.
Yeah. Someone wanted me to just repeat what the items were that were like on the 6-food elimination diet. So it's dairy, eggs, wheat, soy, shellfish, and tree nuts.
It's really hard to do that elimination diet.
Yeah. Dairy is the highest, and then wheat is a close second, and that's WHEAT. Yes, wheat. Just responding to a few things in the chat. Okay, moving on to drugs. So there are several options for pharmacotherapy, with the understanding, unfortunately, that these medications really need to be taken indefinitely. Most GIs don't really have like a stepwise manner of how they introduce these, but let's just start with the easiest one, proton pump inhibitors. So these are cheap, with minimal side effects, but studies show that about 40% of patients with EOE just being on a PPI will achieve complete response. But that's, less than half. They just have this anti-inflammatory effect that has nothing to do with GERD. So a lot of people like think, oh, they must also think I have GERD. And yes, it can co-occur, but it's really this anti-inflammatory effect that can make PPIs very helpful in some people. The next one is topical steroids. So these are swallowed either from mixing it with their coating, they mix it up and they swallow it every day, or they'll like spray it, which is basically like inhaling it in. And so that will coat the esophagus on its way down and treat the inflammation. And it's upwards of 90% effective, but again, needs to be taken long term. The downside is that there can be a small systemic absorption with side effects. And it's annoying to have to mix this up and swallow it every day, but it is an option. The third and final option that's pretty popular is a biologic. So this is a specific type of medication that's either injected or infused with a specific design to treat that specific disease. So it's either like a small molecule inhibitor or an antibody. And in this case for EOE, it's an antibody, and it's designed to block allergic signaling in the EOE and asthma. So it's injected at home weekly. Again, it's upwards of 90% effective in achieving disease remission. It is expensive and you have to inject yourself. But the only FDA approved medications are the dupilumab or Dupixent and a very specific formulation of the budesonide. Otherwise, PPIs are off-label.
Mhm.
Someone just asked if Reflux Gourmet is a topical steroid. If the person has to swallow it, no, it's not. It's alginate therapy, so it's just algae, and it's a special concoction depending on the company you purchase it from. But the idea is with that and things like Gaviscon, is that you swallow it. It's the last thing that you would put into your stomach, and it kind of floats to the top like an algae raft and tries to block all reflux material, like acidic and non-acidic.
Yeah, so steroids are going to be anti-inflammatory, whereas, like Jess just said, the Gaviscon and the Reflux Gourmet are alginate therapies, so they kind of coat, kind of like a Carafate would coat ulcers or something like that. Um, and steroids reduce inflammatory processes.
And sorry, one more question someone asked is, do you find that insurance companies want patients to try PPIs first before going to steroids or Dupixent? I think if a GI was on answering this question, they would say an insurance company has no role in dictating what comes first, and it would be to the GI's discretion of which type of medication approach they like to do first. But a lot of them would then argue, the easiest front line would just be trying a PPI just because it's so cheap and can possibly be effective without taking something a little bit more intensive.
Um, Okay, and that kind of brings us to this concept of referred sensation. And that's defined as a somatosensory feeling that's perceived to emanate from a body part other than, but in association with the body part being stimulated. And so in this particular patient we have here, we see this one swallowing, and we clearly see that she has cricopharyngeal hypertrophy and a diverticulum with retention of contrast. And she is very sure that this is the location of dysphagia. And she points to her neck and she says, this is where it's happening, okay? But of course, in our practice, we always go low and we screen and we look further to investigate using a standardized protocol, of course. We see that there's a large esophageal deficit, right? In fact, her stomach's in her chest. And so her stomach here is in her chest. So this is her diaphragm and this is her tummy. And she's got elbowing. Oh, I got back here. I'm sorry. Just a moment. Hold, please.
Yeah. And just to give you a check-in stuff, we're at 6:46. So
Okay. So I'm just bouncing back and forth here. And so she even has elbowing of the esophagus. So it's a what came first, chicken and the egg situation. Did this large hiatal hernia, a, her stomach and her chest cause this change in hypertrophy in her throat over time? Probably. But we need to take a look and not just stop. We certainly would have missed the mark if we only treated, if our surgical partners only treated the cricopharyngeal hypertrophy there. So we know that oropharyngeal and esophageal impairments occur simultaneously. And the inclusion of a screening may adequately assess dysphagia and promote multidisciplinary care. And if we just stop at the UES, right, create a care plan, we're not including our colleagues to fully investigate. We're doing a disservice to our patient, absolutely. So this is a great position statement put out by the ABEA a couple years ago, and they note that if an esophagram is not being performed, then the VFSS should include an esophageal screen, and of course, following a standardized protocol is going to help you stay in line with ALARA principle, which is as low as reasonably achievable. And so let's start the quiz. If you don't mind, just chiming in and just to take to work with you on Monday. What are predominant features of dysphagia in the EOE patient? Solid food dysphagia, coughing and choking, pill dysphagia, nasal regurgitation, food impactions, and slow and prolonged meals.
It's showing. See that they're voting.
We've got 46 participants so far, so we'll keep that going.
Do you see it though? I don't think it's registering.
It's on the next one.
Oh, thank you. Thank you.
All right. Almost there. All right, I'll take it. All right. Yeah, slow and prolonged meals, solid food dysphagia, pill dysphagia, food impactions. So the answers I was really looking for, so predominant features that you're going to see in your dysphagia patient, solid food, pill dysphagia, food impactions, prolonged meals. Absolutely. Those are going to kind of stick out to you the most. Much less you're going to see kind of nasal regurgitation and coughing and choking. Woohoo! Aaron. Gives you a little confetti. And so if you don't go low, so this is another take home for Monday. When you don't go low, you really risk misdiagnosis. In this case, a very significant stricture. Maybe this patient would have undergone swallowing therapy, a bunch of effortful swallows against a web, or maybe the web would have been dilated with neglect of the stricture. Maybe that person would have been sent back to the primary care physician, waited another 3 months to get some other test done. I don't know how long it would have taken to schedule that. That would have been read by a radiologist, taken back to the PCP who would have put out a referral to a GI. In this case, you as the speech pathologist at the helm of the dysphagia consult are really looking at the entire swallow. You're taking the picture, the full picture into consideration, which is someone coming in saying, "Oh, I have food sticking in my throat." They're non-responsive to PPI. It's been going on for years. He can remember at age 10, the onset of the symptoms, and we decide to do an MBS. We decide to look low and get him right to where he needed to be immediately, dilated, biopsied, and living a good life. And so our well-intentioned treatments may be misguided or ineffective. We waste resources, the increased patient frustration leads to worsening of their already existing condition, especially after reviewing this, after screening, he'll have the appropriate gold standard tests. So he needs an EGD. That's going to buy, that's the gold standard test in this case. The screening just said, hey, he failed the screening here for something that looks anatomic. Let's get him to where he needs to be. And he went right there. Next week, got the biopsies, did what he needed to do. And so we identified issues within the mucosa that were very telling. He got the management strategies he needed, the medication he needed, the documentation for insurance purposes that he needed. So if you don't go low, you don't know.
And I just want to add something too, Steph,
Sure.
for viewers who are kind of like, well, why did the patient aspirate? Like, how often was that happening? What's the connection there? And we like to talk about this interplay, right? The intricate, intimate relationship, the interrelationships between the oropharynx and the esophagus. And there's like numerous ones, okay? And so when there's long-standing esophageal problems, it affects upstream and vice versa. Long-standing oropharyngeal impairment can affect downstream. They affect each other, okay? So just like we see problems in patients with esophageal cancer. If you look at their swallows before they even have an esophagectomy, they aspirate. They have like oropharyngeal problems that are diagnosed, like the physiologic impairments. Patients who have COPD or longstanding GERD, that changes and impacts the timing of swallow initiation as well as laryngovestibular closure. Not just the timing of that, but the actual closure itself. And so there's just this big interconnectivity. So if we just stopped here and we said, oh my God, they aspirated, but we don't really understand what was the mechanism behind it. He wasn't aspirating consistently, just on that one time and we caught it. We need to know more information. So to a question there, someone wanted to know, why didn't we just go right to the EGD after doing the fees? Because the fees was like our screener. We were taking a brief look, like what they do as part of their multidisciplinary swallow clinic. And the fluoro study is going to give us a much more robust roadmap of what's happening and the interconnectivity, which is really important to know before any interventions are done. And not just SLP interventions, GI, ENT.
Yeah. And so we've had long conversations with my surgical partner about the aspiration event, kind of from retropulsion from the PES and the sensory response to it. So why wasn't he a sensate to that aspiration? We also do feast. So she will tap not only the epiglottis, but the arytenoids, left and right, for sensory response. And he was sensate. So we were a little perplexed and looked further into it, and actually just had another discussion about it today, that this prolonged, think about how long he's been dealing with this since age 10, probably like middle adolescent, all the way through 27. And he has a blunted sensory response to the aspirant material. And kind of like when we have irritable larynx syndrome and we have a hyper mediated SLN response to stimulus. So we were discussing that, and there's not a great deal of literature on EOE and change in sensation. So certainly in the process of getting this out as a case study, because it's very interesting. And I know some people responded, I would start some therapy after the fees. And so I think, it's a logical step in a way. If you see a problem, you want to treat it, make it better. But I don't think we fully understood why that was happening. And going to an MBS next helped us understand what was happening at the cricopharyngeal space. It's a barium swallow, of course, so you're seeing movement of liquids. Whereas if we just jumped to my partner doing an EGD right away, we don't know what the crico looks like.
There's
And
a couple of comments in the chat too I want to answer or address while we're on this topic before we run out of time. couple of people want to know why not just start this patient with a fluoro first, and also weren't the symptoms more indicative of an esophageal problem? Most doctors, when they are presented with a patient who's saying, I'm having difficulty swallowing or I'm feeling like issues here, their frontline order is a fluoro study. So this patient just happened to be coming into the clinic with Dr. Watts and their laryngologist, and they do a fees. But if this patient was coming into Mayo, we would start with a fluoro study, 100%. And so that gives us the roadmap. Very few doctors are just going to order an esophagram. So with the majority of, and remember, the patient's like telling the doctor he's feeling like solid food sticking up here. So when there's a lot, it might sound a smidge esophageal, but the patient's localizing the problem up higher most of the time. They're not good at localizing where the problem is, and the doctor doesn't have any special sort of algorithm to be like BFSS or esophagram, which is why it's important that if your patient's coming to you, you should always do, if you can, an esophageal screen. We suggest the rest. You need to at least visualize it in the AP position. And it's important that the things that we're giving the patients are actually making it down past their chest. We are following it through. And that way we can give the full robust picture.
Yeah, so this gentleman, again, presented to us from a PCP referral for food sticking in his throat. And we ask much more involved questions about his dysphagia than his PCP would, right? And then when you see our multidisciplinary clinics, we see about 24 people a day. And so it varies from voice concerns, airway, and dysphagia. So our intake is starting with a fees, but we, order an MBS. But for scheduling, for seeing the both of us at the same time, we start with this fees evaluation. And a lot of times in outpatient clinics across the US, they have fees as well. So it's important to understand these red flags in the case history, why we would order an MBS, and of course, why would we go low. And when it comes to meeting educational demands, this hasn't really, it's not a new topic. Dr. Easterling and this was also Dr. Belafsky right up in 2015. And most of the education in the areas of esophageal disorders are obtained from postgraduate continuing education coursework, kind of like what you're doing tonight. Or if you're able to work closely with GI or an esophagologist. And symptoms of esophageal dysphagia and recognition of the presence of esophageal dysfunction from instrumental evaluations performed is very important, especially such as an esophagram, if you're so lucky to be in one of those states that you can do an esophagram same day. In a word on the esophagram and the fact that it's performed by a tech. Just yesterday, what's today? Wednesday. Oh, they're going by so quickly. Monday, we were in multidisciplinary clinic, and we had a patient, head and neck cancer patient, radiated in 2005. Such an amazing, lovely gentleman. And when he kind of found out that day that we were going to do another fees, he kind of froze. He said, like, the last swallow study was truly traumatic for him. They had him, how he described, waterboarding him as he was laying on his stomach, flipping to his back. And so there was really, and that was just like a month ago. So they were doing a barium esophagram, right? They were doing an esophagram, no consideration of what this gentleman had gone through, his oropharyngeal dysphagia. And so it was really unfortunate because in the paper that Jess just published, she speaks to the presence of, and the other one that we published last year, the presence of esophageal dysfunction in your head and neck cancer populations. And so I think that we as speech pathologists are so poised as the dysphagia specialist. And, we've been talking about this for decades, and this is a lovely write-up from Dr. Easterling on the educational aspect of it. But we are very poised to incorporate our knowledge of the oropharyngeal function into the team, screen the esophagus, and add value to the dysphagia workup. And so it really takes collaboration. And this is two or more people working together to achieve a goal. And in this case, part of the collab, we have SLPs, GIs, radiology, and ENT, all with the common goal of promoting a robust visualization of the esophagus during a swallow study, and moreover, understanding who's at the reins of helping this patient, who's coordinating care. What is the role of SLP in this very difficult thing to manage? It has a lot of people involved in it, and a lot of perspectives. And if we don't collaborate, we're absolutely missing things. And I think one of the biggest travesties is how long it takes for a patient to get care. It's a wheel and spoke model that sends someone back to their PCP to order another test, right? Back to us, back to them.
Nobody's talking.
And the communication is quite difficult in those scenarios. I don't know if it's just me, or if if the 194 people on the call also experience some of that in their daily practice. But the goal is to kind of change the way we look at swallowing, especially in the era of a dichotomized swallow, which we live in. So thank you so much for joining tonight. I think we're a little past time, but I'd love to take questions, and I was hoping to open this up to more questions.
And just one last little point, remember the cricopharyngeus muscle is the window to the esophagus. And so when you see something going on there, it's usually something going on below. It can also be pharyngally mediated, and it's your job to figure out what's causing the cricopharyngeus muscle to misbehave.
I know a lot of people need to log off just because we're at the top of the hour, but we will stay on for questions if you all have time to stay on for questions. But before we do that, if you are interested in ASHA, use the surveys in the chat. And then if you're wanting a certificate of completion, just send us an email at tims-univ@tims.com, and that information will be sent out via Zoom as well. And we ask that you complete the survey by January 22nd, so a week from today. And with that, there are a ton of questions in the chat for both of you, Jess and Steph. I don't know if you want me to read them or if you'd like to kind of go through
Read
their
them, Brooke, but really
Okay.
quick before everyone starts logging off, we are providing rest training 4 times in 2025, and our next one's February 1st. So please register and join us. It's not just about learning rest and understanding all the nuances and then implementing at your facility. It's actually like forming dysphagia teams and how to basically change the culture at your hospital for the better.
Absolutely.
And another thing that we wanted to mention for those that are on or that have access to TIMS MVP, the rest is now available in TIMS MVP. So if you update your software, it is in the software. So we are super excited about that. So with that, we'll go ahead and answer some questions. There has been a lot of discussion about radiologists believing that EGD is the best way to assess the esophagus. I don't know if you want to provide kind of a general statement about that, but I saw a lot of comments about that in the chat.
EGD is when you're asleep. So all they're looking at is anatomic. Even if the EG or the GI doctor puts a statement like saying there might be motility or dysmotility, that they can't know. So that's motility is assessed with esophagram visually to get at least a ballpark, which is why we would do the rest screen during fluoro, but then it's actually diagnosed with manometry, high resolution esophageal manometry.
Yeah, and just to add to that, I wouldn't say best. I would say one of, right? There are different modalities to evaluate esophageal function. Manometry, to understand the manometric properties of the muscle contraction and impedance, or impedance is bolus flow. EGD, like I said in this presentation, mucosal irregularities, biopsies, seeing, right, kind of like our endoscopy. So we can take biopsies and see, and of course, EUS, PET scans, CT scans. You're going to look at the layers of the esophagus. There are just so many different tests. It's not which one's the best. it's the best for that person for what they're presenting with, right? And what we see on fluoroscopy study and screens. But yeah, I wouldn't say what's the best or not. I would say what's needed for that patient.
Claire asked, can you speak to the side effects of long-term PPI use? My understanding was that PPIs should be used as a short-term solution while diet and behavioral modifications are being initiated.
I
So
mean, I know
diet
how my
and
GI feels about it, but I don't think it's for me to say.
yeah, and I think that's a great question. So just of note, from the collab, we're going to have a lot of offerings this year from laryngologist, a GI, and just presenting on these types of things. So our lectures, we're going to have some free case studies just to hang out for an hour and look at cases. But there, we will have GIs talking a little bit more about PPIs, the use of PPIs, and a little bit about that literature that came out, kind of scaring everyone for long-term PPI use. So I don't want to speak, over the GI. But in this case, in a chronic immune disease, the use of a PPI is warranted to facilitate improvement in what they're suffering with, which is chronic inflammation.
Stephanie has a really great question. She said, what is the conversation with your radiologist to utilize this protocol? And what are they documenting in their notes? We already spoke with our radiology team and got approval for sweeps, but I imagine if we change the protocol, they will have a lot of questions, which I would be happy to answer.
Yeah.
Oh, so you, what was the question again?
What's the conversation with the radiologist? I mean, that's
Oh,
what there's a lot to say.
yeah. I apologize. The radiologist, you know, it's the study being performed by the speech language pathologist, and it's not a complete swallow without a screening. And here is a validated research protocol that we use at our institution, with a high diagnostic yield in terms of screening. It's efficacious, quick, and um, highly sensitive and specific. So haven't had too much of a problem, luckily.
Awesome. And I know we're definitely not going to be able to get to all of the questions because there are paragraphs and paragraphs. I'll ask you one last kind of general one just to be respectful of your time, but a lot of people had comments and questions about how to engage with difficult radiology teams. Any just kind of blanket advice you could give here in the last couple of minutes?
Take our course. Ha, just kidding. No, radiologists, it's not that a lot of them really care so much that they feel strongly that we shouldn't be looking at it. I mean, there might be some, but that's not the preponderance. They just are not familiar. They also are used to speech pathologists coming in with no standardized protocol and just taking long time trying to see what they can look at. And the education component with being able to have a conversation about that. So when you present a protocol and you know your stuff and you sit down with radiology, you will probably be much better received.
Yeah, and we do have to have an evolution and discussion of semantics, like non-diagnostic scan down IC and things like that. It is a screening protocol. Screening implies a pass-fail criteria, and in addition to a pass-fail criteria, there are operational definitions you follow. So there's nothing left up to the imagination. You're not pulling terminology out of textbooks, calling something a hiatal hernia, calling it a stricture, calling it a web, calling it a diverticulum. You're just simply describing bolus flow. And I think that that's really important, that despite the varied semantics we have for it, like a follow through, a sweep, a non-diagnostic scan down, a looking for what is it, emptying or
Drainage. Esophageal
clearance,
drainage.
clearance or drainage. Those just aren't common terminology that your GI friends and esophagologists are using, right? It's not. And so we're not talking the same language. We're not even, you know, eh, near, on the same page there. So I'm sure that that's a big reason why radiologists have hesitancy, because I think it just speaks to the educational component, which Dr. Easterling has been writing about for years. Brodwin Jones since the 80s, when I was a baby. This I'm not. It's not a new thing. I think what's new about it is pushing pushing for a place and advocacy and a tool that's easily implemented. We've published on this being implemented in an outpatient facility, not at a not at a tertiary academic care center. I'm analyzing a data set right now from the acute care, so not just outpatient, but inpatient. It's easily done. And when I say high diagnostic yield, that means that these screens are taken and validated with further testing. Um, you know, Despite the barriers that are reported, they can be overcome with institutional and administrative support.
But
Which
hold tight
comes
because we have more studies coming out. So Dr. Watts and I are working together to provide even more information that's going to be more in support of what it is that we're trying to do. And we have a perspective paper going to ASHA that hopefully will be published soon. And it just literally recaps everything we just talked about, and
yeah.
the GI and ENT input on the
And
need for esophageal screening during the VFSS.
And it'll be quite a long road, but I think that right now in the age of, separating these things, it's just more and more case examples. I mean, I could probably talk to you all through the night about case examples of why, we need to look, and we need to look in a validated, standardized way, in a robust way, not just with this very small bolus amount to the aortic arc, and say, I screened. Again, that terminology is just not consistent, and that's why radiology has pushback, part of it. But once we start to, show the validity of the, what you can gain from this. Also, there's a paper coming out on MREST, which is a modified rest. So if you do have pushback, which bolus trials you really need to use and which you don't, or if there's a question about severity of oropharyngeal dysphagia, what you need to stick to. So yeah, more to come.
And the financial feasibility of all this and what does it mean? I think, money talks. And so when we have more of an idea of finances and what that means, like, does it mean more esophagograms? Will it actually make the radiologists more money? Is it going to be beneficial for their time and energy and so forth? So, yeah, not just about patient care and safety, but also money.
Awesome.
Thank you, everyone. You're very welcome. You're very welcome. Thank you all for sticking around.
Thank you, guys.
I know there's a ton of questions, like I said in the chat. Feel free to check out Stephanie and Jessica's website. I put that in the chat, and it's also linked on the TIMS website. So be sure and check out all the resources they have there, and follow them on social media to learn more about these topics. And with that, we'll go ahead and close out for the evening. Thank you all very much for being here.
Thank you.
Trying to. Thank you,
Bye,
guys.
everybody.